Welcome, folks, to Freedom Hub's Health, Biz, and Politics webinar. I'm Charlie Froman, joined by Jim Grapek, my trusty co-host from the Pavilion. And today's topic is something that is really important for a lot of people. The cartel is so huge, people just assume that there's lots of fraud in it. Let me show you our screen. A little housekeeping up front, your-mp.com. That's our site. At that page, you can see the health businesses that we promote under your health tab. We're big into enabling the cash market and self-testing so folks can seek better quality care that is in the integrated healthcare space. And you'll see Genexi and our Wow Cash Appointments app. Check those out. And at your Media Hub tab are our weekly webinars. We've been going on for 5 years every week, except holidays. And we have the previews for every coming guest on the page you can look at. And down at the bottom, you can see where our links are to watch the recordings. And there they are. For both channels, the health channel today on Wednesday and the Freedom Hub broader topics channel on Thursdays. And today's topic goes back to my beginning in politics on Capitol Hill when I worked for a guy named Congressman Geekus of the capital of Pennsylvania. He got great press from targeting fraud in Medicare, specifically durable medical equipment, DME. And it was kind of frustrating for me because I wanted to get more into the supply and demand of healthcare, which I have done with that Cash Appointments app that you saw that we promote here at Freedom Hub. Because in our opinion, in the macro space, we believe that helping doctors accept cash payments and helping patients shop on cash is probably the most important panacea to fix the fraud problem, because right now, prices are opaque, they're distorted, they're hidden, and it's a top-down cartel controlled by hospitals, pharma, and insurers, and the government. And the patients are pretty helpless and useless on the demand side of that curve. What was interesting before I turn it over to Jim to get more detail about our guest and topic is at his LinkedIn or Twitter account, Jeff Leston, who was an early engineer in how to systematize detection of fraud, claims that there's enough waste in Medicare to avoid the cuts that most of us know have to happen to address the debt, because it's, a quarter of the budget are these entitlements that run on an automatic pilot. And he should get his info to Robert Kennedy, because Kennedy and his angle of the Democrat Party believes you can solve the debt just by cutting defense, which is ridiculous. If you're not brave enough to tackle entitlements, you're fairly useless. But if you can have a freebie to cut Medicare just with fraud, that's a tall claim, and we'd love to hear about that. So it becomes, a significant topic to discuss. And with that, Jim, take it away.
Thank you, Charles. I haven't been in the lobbying area in government, but I do want to actually mention a couple of things and talk about, address the question posed by our topic today, which is stopping medical fraud an oxymoron? So I come from the practitioner and the health side of it, and maybe from the citizen, consumer, patient side. As many of our previous guests have pointed out, our entire medical system really is built on fraud, at least a big portion of it. And about 10 years ago, a researcher at one of the top researchers out at Stanford, Dr. John Ioannidis, published a paper that basically said between a third and a half of all medical science, I mean, the science that the diagnoses, the treatments, everything our doctors tell us that science is based on, is false. It's just incorrect. And that was parroted, or at least put out there in some of the, I want to share a screen here for a second, from Newsweek, when this article came out that said basically why almost everything you hear about medicine is wrong, and ran through this. At the same time, the Lancet, the New England Journal of Medicine, were backing this up and saying, yeah, we've known this, we see this, the whole system is really broken and we have to do something. And in my mind, I was really excited because I thought, well, first of all, I had a doctor that I thought was picking up on a lot of the false science when I went to him. But other than that, that this might be an opportunity to fix everything, that people would say, okay, let's stop, and let's look at the problem, where is the science weak, and correct that, maybe bring in the more natural therapies, integrative medicine, functional medicine, things we're now seeing, but this is back around 2010, 2011. And at that time, even PricewaterhouseCoopers wrote, Western medicine was failing even in the most advanced nations of the world. And the fact that more than half of us around the globe in the Western nations had chronic disease, at least one chronic disease, certainly is an indicator that medicine was failing. But unfortunately, it's no surprise, I think, to all of us that nothing happened. I mean, it was kind of like it blew over in a few weeks, just like all the other news items. Nothing was ever done, and it was business as usual, except for us, the health biz and politics followers, the cash patient people, and people like our guest today and Charles and everyone else that is working to bring this out to the public and make a better system. So again, it's probably no surprise that fraud goes into the medical payment side as well and stuff. And let me bring up our guest's website. I have it here. I wanted to show the Twitter account. Okay, there we go. So I saw this on Jeff's account, like how Medicare and Medicaid fraud became a $100 billion problem for the United States. And to me, that was like unbelievable. I mean, that kind of money. So I think we're going to talk about that. Jeff has significant experience, I saw from his LinkedIn site, in the financial services, technology sector, healthcare, kind of all where they intersect. He was, as I wrote earlier, created in the 90s and implemented the technology behind the Fighting Fraud and Protecting Senior Care Act, which passed in 2018. So clearly, Jeff has a lot on the ball. And with that, Jeff, let's turn it over to you to fill us in. I'll stop my screen share here and take it away.
Thank you, Jim. And Jim and Charlie, I appreciate the chance to speak with you and your audience. I kind of liken myself, I call myself the love child of Sisyphus and Don Quixote, and the real reason is of those massive numbers of fraud that we hear about, a lot of them never should happen. Jim kind of referred to it for a second. In my background, in the early 90s, I used to do corporate development and investment banking for technology companies. I was approached by the company that did the anti-fraud system for American Express using one of the early versions of artificial intelligence called neural networks. I called a friend of mine who was the chief of staff at Empire Blue Cross, and I said, hey, Bill, is this a problem in healthcare? And I could hear him fall off his chair. So we actually put in the first artificial intelligence system for anti-fraud detection over 30 years ago. It didn't work very well because Empire Blue Cross, who we were putting it in for, had crappy data. So, the first rule of anything in computers, garbage in, garbage out. So the data was no good. Well, fast forward, I was always interested in fraud. And then really in 2007, 2008, you could see that the government was going to take more of an active role in healthcare than it had previously. And we looked back and, I have to say, what have we done? So what we did at Castlestone was to take advances from the financial industry and migrate them to healthcare. Those of you who have ever read Dave Chase's book or know Health Rosetta, he compares in the chapter 7 of his first book, he compares the anti-fraud performance of the credit card industry versus that of healthcare. And there's about a 100 times the fraud rate in healthcare as there is in the credit card industry. So what we did is we took the credit card industry and the same principles, and we'll talk about some of the root causes and if they're addressed or not addressed, and why they lead to Medicare fraud and who's doing or not doing anything about it. But I think it's very poignant to say, I used to live in New Jersey, and I had Senator Frank Lautenberg's office arrange an appointment at CMS for me. And if you know your business history, Frank Lautenberg was the chairman and founder of ADP. I figured if anybody knew about technology, it would be Frank Lautenberg. So his office set me up. I gave a presentation about fraud prevention at the beautiful Palace on Security Boulevard. And one of the procurement people came up to me afterwards, kind of hustled me into a conference room and said, "We don't really need this." And I was stunned. What do you mean you don't need this? There's billions of dollars worth of fraud. And as we go along, I'll tell you some of my own personal experiences and financial analyses that we've done. Shortly after that, Castlestone worked with a division of, it was Anthem, then WellPoint, then Anthem, now Elevance, has a division called National Government Services. And they were both the processor of outpatient claims and the processor of durable medical claims in the DME program in Indiana. So we were authorized to do a demonstration project showing that we could use the payment networks to prevent fraud. And if anybody wants to know the details of that, I can go into it. But the primary enabler of fraud in the outpatient world is, you know, I have to use two-factor authentication now in order to get onto my AOL account. There is, as I like to call it, zero-factor authentication in DME or anything that requires a physician authorization. It is so simple that a DME supplier, and if you go back to that thing on the LinkedIn page, all they have to do is put a physician's identifier in their claim and it'll get paid. And then months later, the auditors come to that physician and say, "Dr. Leston, why are you writing all these claims for power wheelchairs?" And I look at that list of patients and I say, "I've never seen any of these people." Well, we addressed that. And in 2012, we published a report for Congress because, well, let me just tell you how, and it's actually quite simple. Everybody's got a credit card, and I'm sure many of you have had that call. "Mr. Froman, this is your bank calling. Your card's being used at Pikes Market in Seattle. Do you have your card in your possession?"
It just happened, actually.
Did it really?
Yeah, it's what a hassle to redo all your cards.
Yeah. But the point is, your card company knew in under a second where your card was being used. And it's the same data you get on your statement. We're authorized to sit on the card networks and get those data. So when a health payer receives a claim, we can tell them long before they have to pay that claim that, yes, I was really there, or yes, that doctor actually authorized that power wheelchair for me, which is still a pain in the butt for CMS because they use multiple contractors for the outpatient claim and for the durable medical equipment. So they don't know, at least for 6 months, that there was an actual visit. And by that time, the data's there. Anyways, that report, the conservative end is a 765% return on investment. And I'm sitting there thinking, wow, this should be great. We should really be able to do something, you know, make a dent in Medicare and elsewhere. Well, through a long and torturous process, there was a former Congressman, Jim Gerlach, who asked the GAO to write a report on us. And that report was GAO 16-216 about the use of smart cards in healthcare. Their opinion was we could address a quarter of the fraud. So if you take, depending upon whose estimates there are, $150 billion between Medicare and Medicaid alone, if I can still do arithmetic, that's over $40 billion a year. So conservatively, I think we could have probably stopped $300 billion plus worth of spending in the last 10 years had Congress done something. Now we can talk about that as well. It's interesting to me, and I'm trying not to be political about it, but about that same time in 2014 or so, Ron Wyden, who was the chief Democrat on the Senate Finance Committee, which gives Medicare its money, wrote a piece about smart cards, saying it's a wonderful way to prevent fraud. The bill that Jim mentioned earlier in 2018 actually passed the House. And who do you think killed it on the Senate side? Ron Wyden. I looked at his political contributors, aside from Nike and Intel, which are obviously big presence in Oregon. The healthcare industry, the cartel, are his biggest campaign contributions, particularly since he's now in the Senate. He's the head of the Finance Committee, and they're the ones who give Medicare their money. So I thought that was the other interesting thing was there were 4 bills about us in that decade about Medicare fraud. A couple of them were brought by Senator Tom Coburn, who sadly passed away a couple of years ago. Tom was a doctor. And at the time that the GAO report came out saying that we could address 1/4 of the fraud, the Congressional Budget Office has to score all these bills. Well, and I'd be happy to send it to somebody. All 4 of those bills, as I like to say in quote, air quotes, nonpartisan CBO scored all of them a 0. Yeah, I'm looking at Charlie's face going, what? One government agency says we can save $40 billion a year. Another government agency says it isn't worth anything.
What is CBO?
The Congressional Budget Office.
Yeah, they're not too friendly.
No, they are not friendly at all. And in fact, their excuse was, well, we can't really give a financial credit to something that, a preventive measure. It has to be a recovery. Now, those of you who are familiar with Medicare and Medicaid probably know the term pay and chase. This was a ringing endorsement of pay and chase. So since that day, I have kept a tally of cases that would not be possible to commit Medicare and Medicaid frauds and a couple of private cases. Note the private industry doesn't air its dirty laundry in the media, but Medicare and Medicaid, they like to beat their chests about who solved the case. Since 2016, just what I can find in the media, I have $21 billion worth of fraud cases that wouldn't have been possible had we been on watch. And the reason is those are all having to do with identity theft and misuse of identities, which Medicare and Medicaid, we've told them about for at least 10 years, and the theft of physician identities, and nothing's been done about it. And to me, the capper on that, talking about DME, was in the original Affordable Care Act. And those who are interested, I happen to know it's section 6402, which required a face-to-face visit to authorize both durable medical equipment and home care. Why? Because those are 2 very high fraud, high risk programs. Of course, the industry pushed back. They were never implemented. We did our pilot where we could demonstrate it. A year ago, I was on a webinar that CMS held about DME. And they said, there's going to be 46 DME codes that are high risk that we're going to require a face-to-face visit for before authorizing. And I'm sitting there thinking, oh, great, finally, somebody's listening. So I type in a question. How are you going to verify the face-to-face visit? Whereas, I'm not an attorney, but I've been told any good attorney only asks a question that they can answer. We can verify it because we're getting the same data off the card networks that Charlie found out about when he got his card declined. So that question got read, and somebody in CMS who has probably no technical background or experience, well, we're going to look at the medical record, which to me is absolute nonsense, because they're not going to do that for every DME claim. And of course, as we know, medical records are easily forged and manipulated for this purpose. So even CMS telling us that they're going to go stop DME fraud by verifying face-to-face visits, which they were supposed to do 10 years ago, and we proved that we can do it, hasn't done it. Now, a lot of this, and I'm sure many of you, or a few of you, maybe you read the same things I do about identity theft. Senator Warner now is looking at cybersecurity in healthcare. I called his office, and legitimately so. He's concerned about if your record is stolen and somebody else uses your credentials to get service and they're prescribed a drug you may be allergic to. So let's say on a refill, you get prescribed that drug because it's in your record and you have an adverse event. I said to Warner's staffer, and I can't remember who it is, and oh, by the way, identity theft is probably the biggest driver of fraud in Medicare. And all of a sudden, they didn't want to talk, because I think between Congress and Big Health and a few other people, there's no incentive to actually manage the cost of Medicare. The problem is worse in Medicaid for some structural reasons, but there hasn't been a concerted effort to stop healthcare. But my point is, the technology exists and it's there. Now, one final point. If you recall, about 4 or 5 years ago, CMS took the big leap that they were supposed to take 10 years previously, and took Social Security number off the Medicare as the Medicare identifier. They really hit it well. They put a letter after that, and that was your Medicare identifier, your HICN, your health insurance identifier, and went to a new number, a combination alphanumeric characters, supposed to stop fraud. And I wrote, in a couple of months, it'll work. 2 years, it won't do anything. The same number will be on 18 to 20 computer systems for every individual. It'll be transmitted. It'll be stolen. In fact, there was just a case in Miami recently where somebody was convicted of trying to sell 2.6 million Medicare identities. So that's the primary driver of fraud. The way we've approached it is, even if it's stolen, you could verify that the person was there. So my question has always been, why have we had such resistance from CMS? And I know you mentioned that bill from 2018. They asked me to sit in on a drafting session, and they said, oh, we have to get the AMA and AHIP and the Blue Cross Association there. And my question was, why? Well, they're part of the discussion. So, of course, the bill was watered down, and then it was killed in the Senate. But at least, the House could say, look, we tried to do something. So the real answer is there's very little, if any, incentive. I've never seen a federal government budget that is willfully saying, yes, please look at what I've done and make me more efficient, because the next time they go to Congress, in their infinite wisdom might say, well, you overspent by X number of $1 billion last year. In fact, there was a story this morning that they paid Medicare Advantage plans $78 billion in excess of what they should have. And Charlie, I think I even put that, it was a Forbes contributor story. So that goes for Medicare, that goes for Medicaid. These are profit-making entities. So, extracting as much as they can from the federal government has made it like shooting fish in a barrel. So that's our story. The fraud is there. The fraud is preventable. I'd be happy to answer questions, and at sometime even send you the data that we have.
Thank you, Jeff. Wow, that's depressing. No,
Yeah.
business as usual, I guess. Charlie, your hand's up.
It is. And folks, if you don't mind clicking the raise hand icon to get in the queue, I'll just start asking questions and see where it goes. First, a comment. I was just in DC last week lobbying, Jeff. First time since the COVID hysteria. And it was actually depressing to be there. It's just a vortex of evil. And coincidentally, I'm in Virginia. One of my meetings was with Warner's, one of his staffers, a low-level guy, the legislative correspondent, but the guy that helps the Health LA. And in diverting from our topic, he did mention that Mr. Warner is very interested in cybersecurity,
Absolutely, yes.
but not too much.
Yeah.
That is and Wyden, my goodness, I hear so many folks saying what a good politician Mr. Wyden is. Just good morals, good attitude on issues, and good for him for writing the letter, the article on smart cards. But what a coincidence that he couldn't pass your bill.
Yeah.
I mentioned RFK earlier, Robert F. Kennedy, and I think a lot of Trumpers, libertarians, independents are backing him, health freedom people like us. Although I wouldn't mind Trump being in it because I like bulls in China shops making noise. I like that because it is such a cesspool. That is RFK's target, the special interest capture of the bureaucracies. He's still a big government guy. So, he still has some old presumptions that, of course, government monopoly medicine can work, despite the fact that it can't work. But he's becoming more open-minded on all these old Democrat shibboleths the more you watch him. So I think his administration would be the type, theoretically, I think, that would be open to serious attacks on special interest influence. That's my thinking. A lot of folks agree with me on that. Do you have any thoughts on that? Have you thought about RFK's attack on special interest capture, how that might affect what you're doing?
No, this is a revelation for me, Charlie. I just know that he's put his hat in the ring. I don't know too much about him except for his family lineage. I don't know much about his positions, but certainly worth a conversation with his staff. So, and if right now the system is paralyzed just because of the influence of these large, the health lobbies. And I started writing a book. It's funny. I haven't done it, but the first chapter is called Eisenhower Warned Us, and it's the parallels between the military-industrial complex and the health complex that we have today.
Yeah.
And if I can do one follow up, Eisenhower to the health cartel. You just mentioned Medicare Advantage, but second question, then Jim, I'll let you move it on. I was going to ask, because they're theoretically hiring the BUCAs to manage Medicare, impressed a lot of politicians as having hope to get some efficiencies there. There's been a lot of pushback recently that the Medicare Advantage plans aren't necessarily better for efficiency or for patients. I mean, they do rely on the managed care model, which means rationing through narrow networks. So already your best doctors aren't going to participate. And they have to take their cut in profit. And of course, that gets to the MLR for Obamacare plans. That minimum loss ratio gimmick gives them an excuse to collude with hospitals to make those itemized bills opaque, distorted, and confusing, and worthless. So comment on that.
Well, you just mentioned three initials that to me are another enabler of inappropriate payments. The MLR, as I've written in posts previously, I don't know I can't remember whether it's 15% or 20%, but the real point is 15% of a larger number is a larger number. So, there's a disincentive to do anything for actual management of costs because that profit pool gets bigger as the costs get bigger. And from our own personal point of view and our company point of view, anti-fraud expenses are actually, they're part of the admin. So they go against the MLR. So what the BUCAs and everybody else did is they said, well, screw the anti-fraud stuff. Let's just put it into marketing and get more people.
Wow. MLR is a huge topic at Freedom Hub.
Yeah. It's a great disincentive to do anything efficient.
Okay, Charles Ford, I see your hand up.
Yes, sir. An amazing conference today. Thank you for your information. I want to change the point of view and maybe enlighten as to why some of this works the way that it does. As Charles has said, a monopoly never works, a government monopoly especially so. And we've touched on some of the other symptoms, but here is the root cause. Here is the real problem, is that if you're a bureaucratic administrative agency involved in government, one thing you're not interested in is cost savings. And the reason for that
Absolutely.
the reason for that is, and never ever take your eyes off of this, money is power. The bigger you grow your budget, you grow your power. And anything that reduces the budget or anything that creates value or lowers cost probably diminishes your power. And as long as you understand that, then everything that happens with Obamacare, the CMS, the cost plus system of doing things, whether it's military or in the medical field. And let me address that just briefly, and then I'll shut up. What happens in the mindset is if you go in and let's say you're selling a service or a product or a value or a cost savings, something that's going to work and make an improvement. The first hurdle you have to overcome is you can't price it below what they're now paying, because that reduces their power. So that's that you can forget it at that point. That you can forget that's gone. So you have to go in and price it at where they are or just above with a couple of added features. And then as you implement, you do the cost plus. You do the cost plus. We've made a change to what we've agreed to do. So now we're going to get paid more for it. And the more you get paid, the more revenue goes into that department and the more power that department has. That's the endless funnel in a nutshell. And to Charles's point is Kennedy believes that it's just a matter of putting good people in place for a government bureaucracy to work. He is totally wrong on that for all the reasons that Charles has talked about. But I would advise and encourage you to look at the whole panoply of RFK's political views and what he has said and what he does. And I would say this about RFK. Everybody else is running for the job of president. RFK wants to do the job. And I think that with his character, which he has and none of the others have, and his courage and his convictions is why he is a viable candidate for the presidency. And I think would make some improvements in our bloated health system.
Yeah. Charles, if I could just comment for a second, you're absolutely right. And that's the rock I've been pushing up the hill. And in fact, if I did an analysis just for Yaya's once, and even based on the numbers that the GAO and the government assigned to our capabilities, if they had implemented something like what we've done 10 years ago, we would have spent $1 trillion less over the last 10 years in health, in Medicare and Medicaid, because that gets rolled into the subsequent year's budgets. You're absolutely right.
Wow. Charles, you're back with your hand up.
Yeah, I might put some folks on the spot here. Dr. Montalvo, if you want to unmute yourself and comment about what I'm going to say now. That is what Jim said in his intro about Professor Ioannidis at Stanford doubting the veracity of, a third of the studies printed in the medical journals. And I believe the New England and Lancet journal editors said that they could not have any confidence in the veracity of these studies. And Ron Bailey at Reason wrote an article about the failure of most studies to be reproduced. And when you can't reproduce an outcome, you know the study was fraudulent. And that gets to Jim's point about half the population being chronic. We spent a lot of time today, Jeff, rightly so, on the status quo market fraud around payment and IDs. And, you know, some of the causes being what they baked into Obamacare with the MLR, or like Mr. Ford said about, you know, the bureaucratic incentive to, you know, keep the Jeff Lessons away from here. What a hilarious list you mentioned. CMS saying we don't need it.
Yeah.
CBO giving you zero benefit from preventive detection. Unbelievable. And yeah, I knew Tom Coburn. He was amazing. So why don't you give a brief comment, or Dr. Montalvo, do you want to build on that?
Yeah, I would like to, Charles. I think Dr. Ioannidis was being generous in the fact that a third of the studies were fraudulent. I believe over 2/3 of those studies are fraudulent. Based on my analysis, especially going through the pandemic, a lot of these studies are skewed so they would give a positive outcome because the people who are doing the studies want to get more studies done by the pharmaceutical firms through them. So they're looking at more, how much revenue can I make if I make the studies skewed positively for whatever drug they're trying to push, okay? So we have a system that is, I believe, is irrevocably, if that, I can't even say that word right now. It's broken. And I don't think you can fix it. I think you have to destroy the system and recreate a whole new one. Because the corruption is so deep and the capture of the agencies that's supposed to protect us are so deep, there's no way you can be able to get around it. And when it comes to Robert F. Kennedy, and I've been following his work with Children's Health Defense, he knows of the fact of the capture of the agencies of the NIH, the CDC, what's the other one? The FDA, the EPA is captured. Every government agency is captured. And we need to be able to blow them up. And I don't know how we're going to do this unless we have a solid will of Congress and a president that is actually mentally capable and understands the ramifications if we keep this deep state that's in. All right. So, Charles, I don't know. I mean, I've been at this. I was training doctors for 13 years, medical doctors for 13 years in the universities, and even the university is captured by the pharmaceutical firms because the curriculum that's in every university, I don't care if it's Harvard, Yale, Nova Southeastern University, or FIU, it's the same curriculum. It's just depending on the institute, it's going to cost that student a lot more to go to. If you go to Harvard, it's going to cost you $500,000 to go through the medical school, as opposed to going to Nova University, and it's going to cost you $300,000, depending on the discipline that you're trying to go through. So this corruption is really going through the entire medical system, from the institutions, the universities, straight through our government. And trying to unravel that, it's a Herculean task. And we really need to, as you know, you're trying to do on your end, try to come up with a system that really goes back to the old system back in the 1940s, 50s, where you had doctors that are taking cash money away from the insurance companies, because the insurance companies are also corrupt, and part of this, where they're paying more for disease care and not real wellness care. I don't know if that's the comment you were looking for, but that's what I feel. And like I said, Robert F. Kennedy knows the system. He knows that all the vaccines are fraudulent. And if he was elected president, yeah, there's some things I don't like about some of his policies, but I know that's one thing that he wants to do is kind of blow up those systems and start again. Hopefully going back to the system back in the 1940s and 50s, and what we've been talking about for, I don't know how long I've been on this webinar for the last 2 years. Anyway,
Thanks, John. Hey, Charles, why don't we turn over to Pam? She put a question in the chat, and I was thinking we should ask her because she's involved with dealing with insurance fraud and some of this stuff, right? Right, Pam?
Indeed. And in fact, man, this has just been fascinating, by the way. And really, my question is, does anyone have enough skin in the game to want to change and lower healthcare cost? Or is it just because everything is, if you will, the employee and the employer footing the bill, and the insurance company is just the pass through, and big pharma wants as much to come through as possible? But do you see any carrier or company that has enough skin in the game to want to change this?
Is that for me?
Yes,
Yeah.
you're the guest.
Well, I haven't found an insurance company a health insurance company that wants to reduce costs. Not a one. And, on the margin, they'll do something with prescription drugs, particularly generics. But there is a whole industry of people like me who are, looking at payments and looking at the fact that the hospital's charging $2,300 for an MRI and the local imaging center is charging $500. So I call that kind of the data arbitrage industry and the transparency industry. But notice that the carriers and the administrators are very hesitant to give companies their own data so they can make up their own minds. There's a whole lot of mysticism. Oh, you can't have your own. What do you mean I can't have my data? It's mine. Even under ERISA, and ERISA trumps all. You're supposed to get your data under ERISA, and people have to fight their carriers. And when they talk about audits, the carrier will say, well, you can audit X% of your claims. This is nonsense. So the carriers, I have not seen one who is, and believe me, I've been banging on their doors for a long time.
I was wondering, like TPAs, captives, does anybody care enough to lower it? Or is it just, because I'm sure I found the same thing you have. Even HR doesn't really care about lowering costs. CFO maybe, but they don't know how.
Yes.
Who cares about where the buck stops?
Well, my experience, and I've written this on some of my LinkedIn posts, they're faced with a double-digit premium increase of the following year. And what's the reaction? Oh, I guess that's the way it is.
Yeah.
And they don't realize, and what we're trying to do and other people is to say, this isn't about wearing the same color shirts and going to picnics and everything else. It's about taking back some of the responsibility to oversee your health plan. I think the oversight has been outsourced as much as the processing has been outsourced. And it's been outsourced to people that have no incentive to act on behalf of the people that are paying the bills. That's my experience.
That's interesting. So I work in AI, and we do individual health assessments to empower the individual to take control of their own health. And, because that always cracks me up. Every commercial, everything that's ever written about health says, be sure to consult your doctor first. Boy, I'd sure like to change that jargon, at least into talk to a doctor who's educated about root cause or whatever. Yeah. But do you think that empowering that individual, since consumer-directed healthcare has shifted, the deductibles are through the roof, do you think that will create enough disruption to start to diminish the fraud and lower some of these costs?
Well, it's funny. The high deductible plans, I call them self-insurance with a crappy stop loss cover.
Yeah. True.
Well, hopefully what we're doing is one of the tools. The problem is that on an aggregate base, individuals don't get the data or the tools that they need to help. And what we're hoping is, because of our structure, we can do like, Charlie, we can call you up and say, hey, wait a minute, you weren't at this doctor's office, yet they're billing. Can you imagine a Medicare beneficiary who gets a bill for 10 physical therapy visits being able to say, no, I went to 6 of those and tell me which ones? No, that's impossible. So you've got to provide the individual with that technology, and that's what we're trying to do. Other than that, the data is at a higher level and it's not available to the individual. It's okay, we're spending X amount on certain drugs. Well, how does that affect me individually? So I'm talking my own book, obviously, but we need more things that are easy for the individual. We say, okay, individual, you're on your own, but we're not giving you any tools to do anything about it. That's
Yes,
the situation.
exactly.
Yeah.
Yeah, absolutely. No, I love that. I'd love to talk with you offline a little bit about that as well, because my own personal story is that I went in for my preventive care visit, had to go to a more traditional doctor just to check a box, and partly because I love to dip a toe in that side of the water just to see what it's all about. And right now I'm looking at a bill for it's not even $100. I cannot get a breakdown of why I'm getting a bill for anything. Yeah. I've asked 4 times for the CPT codes. I've asked what exactly is my responsibility and why. They will not give it to me for anything. So to your point, the individuals are expected to be good consumers, but we cannot get the information.
That's rule number 1. Get your data.
Yeah, I agree. Well, thank you for your presentation. I appreciate it. It's fascinating.
Thanks.
Linda, your hand's up next, I believe.
Yes, because Charles mentioned John Ioannidis, I would like to tell you that I know this wonderful, smart person very well. I have all his book. I follow him. You cannot imagine how honest he is, but how much he was bullied, segregated when he was in Greece, at a point that he had to leave the country and go to California. But still, he's very active. I really appreciate him a lot.
Yes, a Greek compatriot. Okay, thank you. Bob, I think you're next. Unmute, you're okay there. Can't hear you. Yep.
How's that?
Yep.
Yeah, my background is construction and development, and part of that was converting a shopping center that was in 3 sections into medical office condos. And this
Big
started
business these days.
about, what's that?
I said that's a big business these days.
Well, what I found was in my little town, about 50,000, was that once Obamacare came in, it dried up all my solo docs and private docs experience. I sold some space to the hospital, and as part of the discussion on that and some others, I viewed them as a candidate for buying space from me as a customer. I was told when I proposed a surgery center that the location for it was too far from the hospital and they couldn't get their 30% boost. Under Obamacare, they were able to charge 30% more than an individual doc. So they started buying up all the individual docs, and it really affected my business. I couldn't believe that there was a government program that was having the hospitals charge the same procedure and get a 30% boost. And they did some mumbo jumbo that they were worth more. But facility, and they were doing medical office coding. They have since become one of the largest tenants in the building, and the guy's president of the condo association, and they have kept growing and growing and growing. And because the coding for the billing that the hospitals and individual docs were doing was such an art, and it's if you can imagine, a code determines not the procedure, not what was done, but the code determines what you're being paid. It was beyond the skill sets and management of individual docs by far, and even to the level of hospitals. So he ended up becoming the go-to company to get your codes, to get your billing done. And I remember talking to docs that were in tears, individual docs, talking about how far behind, hundreds of thousands of dollars they were behind on collecting on Medicare, and they just couldn't collect. And then the requirements on the EMRs, and these were very capable individual doctors, and they were distraught. They didn't know what they were going to be able to do. So they were just on a personal basis an individual mess, confronting the system of medicine. And this started 8 years. This started with Obamacare, and has come through. And so my friends have been individual docs and clinics and people at the hospital who I know from their various interest in facilities. But not only is it a disease treating system, but it is a billing nightmare that nobody understands.
Well, Bob, there's three things that were recently in the press I just would comment on. There was a case where, and I think you were alluding to it, these systems, you can't call them a hospital anymore. They're a system. First of all, they're consolidating like crazy. I'm in the St. Louis area, and your healthcare is either BJC or SSM. And the BJC actually took one of the big supermarkets in my town and converted it into a healthcare facility. So I'm well familiar with that. But what you said is they bill at different rates depending upon whether it's inpatient or outpatient. And this is something else I've had a discussion with CMS about, time and location. So they get more money for doing the same thing depending upon where it's done. So you've got consolidation, you've got billing shenanigans. So yeah, we see a lot of that every day.
Thank you. Charles Ford again.
I wanted to go back briefly to some of the points that Pamela raised. Well, you have to understand, in the boardroom, they look at health benefits as an unaffordable cost that cannot be controlled. So they just budget a 10% increase each year, and they instruct HR, come in 10% or less. If you want to continue working here, make it 10% or less. And when you do, we'll break out the champagne bottles. Very few people individually or at the corporate level believe that there is any possibility of containing healthcare costs whatsoever. That's problem number one. Problem number two is the same co-option that we've talked about for the last hour goes on between the HR department of most companies and whoever the healthcare broker is, who almost always has Blue Cross and Blue Shield looking over his shoulder and controlling his activity. So what happens is you get your broker who comes in and brings his loss data provided by Blue Cross and Blue Shield and explains why it is their small group had a bad case, so therefore they have to pay a 30% increase this year, and justifies it on that basis. That's the business model that most corporations are captured by. The larger ones self-insure, which has all the same problems that were talked about with a high deductible individual health plan. It's adverse selection against the corporation. It is not affordable. It is variable in cost, and none of that works in the boardroom. And then the last point I'll raise about what Pamela said is you go back to the medical sharing arrangements. They are making strong efforts, and Charles can talk about this in detail, to control costs direct expenses and spend money for services received and make sure that the money spent is the right amount, and also that the service received was what should have been received in the first place. So I just wanted to bring those points up to give Pamela kind of an understanding of some of the things that she's looking at. Oh, one last thing. If a health carrier refuses to provide you health information, call your insurance department. Depending on the state, you may get some good things done through them, because they will make phone calls and they will, at some level at least, make sure that you're provided some healthcare loss information.
Thank you, Charles. We're coming up on the hour. Bob, something quick? Yeah, you're muted again. I can.
How's that?
Yep.
Okay. I work with Virginia Medical Freedom Alliance. The COVID-19 shot, the effects of it, the damage done, and the additional medical cost and ongoing treatment that is not quantified, but it's got to be a cost driver unless it kills enough people to lower Medicaid and Medicare costs. It's a very dangerous thing, and there are many people that have awoken that have become medically cautious and are seeking health solutions rather than disease solutions. And it's we hear weekly in our VAMFA meetings of the vaccine injury.
Thank you. Yeah, that's a good point. I mean, it's coming out all over. Thank God. People are waking up to that. Okay, John, real quick.
Yeah, real quick. Back a month ago, I was in Texas, actually a few weeks back, and I was teaching on the history of homeopathy. And a lot of people know the Sloan Kettering Institute that was supposed to be a homeopathic clinic and turned into an allopathic cancer clinic. But back then, National Cash Register, as well as GM, had their own clinic with their own doctor, and they were using homeopathy. And they were healing people without having to have insurance. A person got sick, they went to the own clinic, the National Cash Register or GM, and they were taken care of by a doctor that was there, and it wasn't part of a medical system. Of course, homeopathy, based on an email, not an email, but a memo that was sent out by the World Health Organization back in the, I want to say, mid-'80s, basically said if homeopathy was instituted into medical care like it is in India, there would be a 50% reduction in costs. But is that going to happen here in the United States? No, the FDA is trying to shut down homeopathy completely here. That's my comment.
Yeah.
All right. Yeah, thank you. And a number of other modalities. So we certainly are familiar with that. So wrapping up, actually, I have a quick question for you, Jeff, and that is, given that nobody wants to fix this problem in the government that you're dealing with, where's your business coming from? Obviously, it must be from somewhere else, or what are you?
Well, I was idealistic when I started it. Then I thought, I'll go hunt for elephants. But our business is coming from self-insured companies that are tired of blindly paying things. So, I say and that's why, the comment about the sharing networks is interesting, because they are both the people that are contributing the payments and, have an incentive to control the payments. So those are the types of people that we go after, the self-insured, the municipal plans, the health plans for municipalities, because it's their own money.
Got it. Any 30-second wrap up you want to give, overview, and tell people how they can reach you or follow you?
The best, and I've got to hop to go meet somebody in the cost containment business. I think I have a 2-hour drive I've got to do in about an hour and a half. And Columbia, Missouri. But the best way to reach me is our website is www.castlestone-llc.com. And you're all members of the club now. So the reason the company's called Castlestone is so I could bury my last name in the company name. So you're sworn to secrecy about that. I'm on LinkedIn, and I'll be happy to communicate with everybody on LinkedIn. As Charlie probably knows, I post an egregious story almost every day of a fraud that shouldn't have happened or warning about identity theft in healthcare. So look me up on LinkedIn and we'll have a conversation. Those are probably the two best ways.